Welcome to our video on obstructive and distributive shock. Let's get started. And here's an overview slide, and we'll start with obstructive shock. And we're going to go over the definition, causes, the hemodynamic parameters you need to know, as well as how it presents clinically, and then lastly, the diagnosis and management. Obstructive shock is insufficient organ perfusion due to intracardiac or extracardiac blood flow obstruction. In other words, a pathologic process inside or around the heart obstructs the normal blood flow. So here we have an illustration showing how the systemic circulation and the pulmonary circulation are so interconnected. And we will use this image to discuss different causes of obstructive shock. For example, in cardiac tamponade, the diastolic filling of both the right and the left ventricles is decreased due to the external pressure put on it. And that pressure comes from pericardial fluid. Another cause of obstructive shock is pulmonary embolism, and that causes obstruction by blocking the right ventricular outflow. And finally, tension pneumothorax decreases the right ventricular venous return due to increased extravascular pressure compressing the superior and the inferior vena cava. So here we see an ultrasound image showing pericardial tamponade. Notice the pericardial cavity, and it's just full of fluid. And that heart is just floating around in the fluid. With every beat, tends to be bouncing around. And here we have a pulmonary embolism, as illustrated on this CT using pulmonary angiography. If you notice, there's a filling defect in the pulmonary artery. And this is an autopsy image of a saddle pulmonary embolus. And note that the saddle embolus simultaneously obstructs both the right and left pulmonary artery. Here we see a chest x-ray image showing a tension pneumothorax. And you can see the hyperlucency in the pleural cavity, which denotes free air. Additionally, there aren't any pulmonary markings beyond the left visceral pleural line compared to that right lung. In other words, air is just building up on this side. Now let's talk about the hemodynamic parameters of obstructive shock. So due to the backward flow from the right ventricle to the right atrium and the central veins, the central venous pressure will increase. And the change in the pulmonary capillary wedge pressure depends on a specific cause of obstructive shock. For example, if cardiac tamponade is the cause, then pulmonary capillary wedge pressure will be increased because external left ventricular compression causes backflow of blood into the pulmonary vasculature. However, if the obstructive shock is caused by either a pulmonary embolism or a tension pneumothorax, then there's actually decreased right ventricular stroke volume. What that means is that the pulmonary capillary wedge pressure will be low. And cardiac index is severely decreased in obstructive shock, and that's because of the decreased venous return or decreased equalization of the diastolic pressures, especially in the case of cardiac tamponade. And decreased cardiac output causes reflex sympathetic overactivity, and that then causes peripheral vasoconstriction, so systemic vascular resistance will go up. And as I mentioned on the previous video, just by default, assume that the sympathetic nervous system is working, and by default will constrict the peripheral vasculature in response to shock. And in the next type of shock, we'll discuss why the opposite takes place. Let's finish up here with obstructive shock. So lastly, with obstructive shock, since blood flows very slowly in the capillaries, then the tissues have more time to extract lots of oxygen. So by the time the blood flows through the capillaries, passes the tissues, and reaches the venous system, then the oxygen level will be low. So the mixed venous oxygen saturation will be decreased. But what does this look like on a patient? Well, obstructive shock is characterized by hypotension, which you probably guessed just because we're dealing with shock and almost all types of shock have low blood pressure. And there's tachycardia, so the heart rate will increase as a way to compensate. And because of all that peripheral vasoconstriction, because the sympathetic nervous system is working, then the patient's skin will be cold and clammy. And all of those findings, as you're likely aware, recalling the last lecture, they're not specific to obstructive shock. So recognizing key features of the underlying conditions is super important. For example, a pulmonary embolism can present with pleuritic chest pain, while tension pneumothorax is accompanied by decreased ipsilateral breath sounds, and cardiac tamponade is associated with Beck's triad. And you may recall that Beck's triad consists of hypotension, jugular venous distension, and muffled heart sounds. Okay, so how do you officially diagnose obstructive shock? Well, the diagnosis actually depends on the specific etiology of the patient's acute presentation. For example, cardiac tamponade is usually diagnosed with echocardiography, and patients with a high pretest probability of a pulmonary embolism undergo CT pulmonary angiography, and then a chest x-ray can reveal a tension pneumothorax. So once you've diagnosed obstructive shock, then your treatment just depends on what is actually causing the obstruction. For example, cardiac tamponade is treated with emergent ultrasound-guided pericardiocentesis and IV fluids to increase the venous return. And that's fairly logical. There's a bunch of fluid in the pericardial sac. You want to remove that, and you also want to give fluids to help their heart increase its stroke volume. Now, management of pulmonary embolism is complex, and it typically includes anticoagulants like low molecular weight heparin, and sometimes, if this patient's had many PEs or they have a contraindication to anticoagulants, then you can place an inferior vena cava filter, and sometimes mechanical thrombectomy is used, and sometimes thrombolytics are used. And the treatment choice depends on the patient's comorbidities and the presence of any contraindications to anticoagulation. Either way, you're trying to break up that clot and prevent future clots. And finally, a tension pneumothorax is treated with emergent needle decompression just to get that air out of the chest cavity, followed by chest tube placement to let air continually leak out of the pleural cavity so that it doesn't build up in there. And just to briefly show you, this is how pericardiocentesis is performed. The needle is inserted within the pericardial cavity under ultrasound guidance. You want to be able to visualize where you're going. You don't want to puncture the heart. You just want to get into that pericardial sac. And then the excess fluid is drained out. Now let's do a quick question. A 58-year-old woman is evaluated in the hospital for acute shortness of breath starting 1 hour ago. She has been in the hospital since a coronary artery bypass grafting was performed 5 days ago. When she stood up from the bed today, she felt short of breath. Blood pressure is 80/50. Heart rate is 145, and respiratory rate is 26. ECG shows sinus tachycardia. Chest X-ray reveals subpleural wedge-shaped opacity in the right lung. What is the most likely underlying cause of this patient's cardiovascular compromise? Okay, so the patient had a bypass graft. She's been in the hospital for 5 days, and then today she felt short of breath when she stood up. So due to her recent surgery and her immobilization, then this patient is predisposed to venous blood stasis in her lower extremities. So high risk for PE. And then when we see her vital signs indicate shock, she is hypotensive, she has a high heart rate, and she has a high respiratory rate, then we're thinking, okay, she's got shock secondary to a PE. At least that's the most likely based on the information we have so far. Additionally, her chest X-ray reveals a subpleural wedge-shaped opacity in the right lung. Now, that's a classic radiological finding of a Hampton hump, indicating segmental lung tissue infarction due to a PE. But quite frankly, this is not always seen. More often, you don't see anything on a chest X-ray in a patient with a PE, but if you do see this, then it just gives you confidence that you're on the right track. So, the most likely underlying cause of this patient's cardiovascular compromise is obstructive shock due to a pulmonary embolism. Now let's move on to distributive shock, and here's a reminder of the sequence that will follow, starting with definition. Distributive shock is insufficient organ perfusion due to generalized vasodilation and fluid redistribution. The three general types of distributive shock are anaphylactic shock, septic shock, or neurogenic shock. So anaphylactic shock occurs due to massive generalized histamine release in response to an allergen, and histamine in turn results in vasodilation. Septic shock, on the other hand, is caused by massive cytokine release from macrophages after they encounter something like an endotoxin. Finally, neurogenic shock usually occurs when the patient has a spinal cord injury. And if you damage the spinal cord, then the sympathetic nervous system will also be injured. So the vessels, which normally constrict in response to sympathetic nerve stimulation, will not be able to be constricted. They'll lose their tone. So in all three of these cases, there's generalized vasodilation, which then causes distributive shock. Now let's talk about the hemodynamic parameters of distributive shock. Central venous pressure and pulmonary capillary wedge pressure are low because systemic vasodilation causes blood retention in the veins, and therefore the right-sided preload decreases. Basically, too much of it is just staying in the veins and not returning to the heart. And the cardiac index increases in cases of septic or anaphylactic shock, and that's due to generalized vasodilation. And that vasodilation decreases left ventricular afterload and facilitates forward blood flow from the left ventricle to the aorta. So again, cardiac index increases in distributive shock. Now it's worth mentioning though that cardiac index is decreased in neurogenic shock, and that's because of the disruption of the myocardial sympathetic innervation. And that decreased cardiac sympathetic tone will cause bradycardia and low contractility. So there will actually be low cardiac output. So in this instance, you can see that you need to think of neurogenic shock as a type of distributive shock, but it has a different cardiac index. It goes down instead of up. Now, as for systemic vascular resistance, it's always low in distributive shock of any cause, and that's because of the massive vasodilation. Now, finally, if cardiac output is high, then blood flows very rapidly in dilated arterioles and capillary beds. Therefore, tissues don't have enough time to extract sufficient oxygen from the blood. So this is a little bit different than the previous types of shock that we've discussed. So what this means is that the mixed venous oxygen saturation is usually high in distributive shock. And once again, neurogenic shock creates an exception. And that's because there's decreased cardiac output that causes slow blood flow through the capillaries. So the tissues extract more oxygen from the blood, and then the mixed venous oxygen saturation gets low. So it might be helpful to think of the cardiac index being low in neurogenic shock, and as a result, slow blood flow through the tissues, which means more oxygen can be pulled out. So again, in neurogenic shock, the mixed venous oxygen saturation will also be low. Now, how does this present? Well, distributive shock, just like any other type of shock, is characterized by hypotension, and patients usually experience tachycardia, although neurogenic shock can be accompanied by bradycardia, and that again is due to the interrupted sympathetic innervation of the heart. And because of all that vasodilation, the skin is usually warm. Diagnosis of obstructive shock is based on the combination of the patient's history, that is the cause of generalized vasodilation, and the measurement of vital signs and hemodynamic parameters. Management of distributive shock largely depends on the underlying cause. Most of the time, we administer IV fluids to increase the intravascular volume and blood pressure. You can also administer vasopressors, such as vasopressin or norepinephrine, and the goal there is to normalize the blood pressure. And typically, you give vasopressors if IV fluids alone are not effective. Finally, intramuscular epinephrine is a first-line therapy if you're dealing with anaphylactic shock, and that's because of its ability to cause bronchodilation and vasoconstriction, so it can help reverse two aspects of that cardiopulmonary compromise. And here we have a table summarizing the different types of shock. So that includes the two that we discussed in this lecture, obstructive and distributive, as well as the two types of shock that we discussed in the previous lecture, hypovolemic and cardiogenic shock. So now you've got this complete table that summarizes the different types of shock and the different hemodynamic parameters. So you can refer back to this before you take a test or when you're confused. Now let's conclude this lecture with a board-style question. A 25-year-old woman is brought to the emergency department due to severe shortness of breath and wheezing. Her difficulty breathing started 1 hour ago after being stung by a bee. She has never had such severe symptoms before. Her past medical history includes childhood eczema that resolved with topical corticosteroids and a mild intermittent asthma controlled with an albuterol inhaler as needed. Her vital signs include a temperature of 36 degrees Celsius, a blood pressure of 70/40, a heart rate of 160, and a respiratory rate of 30. The physical exam reveals diffuse, severely pruritic erythematous plaques. Which of the following is the best next step in the management of this patient? A. IV fluids, B. Intramuscular epinephrine, C. IV prednisolone, or D. Oral diphenhydramine. Okay, so this patient presents with severe shortness of breath and wheezing right after being stung by a bee, and her past medical history is significant for atopic diseases like eczema and asthma, and her vital signs show severe hypotension and tachycardia and tachypnea. And then on the physical exam, we see this diffuse, pruritic erythematous plaque, which makes us think of urticaria. So all of these findings together highly suggest anaphylactic shock. So the next best step in management of this patient with anaphylactic shock is IM epinephrine, and that's to restore the vascular tone as well as dilate the bronchi. So the correct answer would be B. Now this slide reminds us of the management of distributive shock, including anaphylactic shock. So recall that in this case, intramuscular epinephrine is the first-line therapy. Now let's discuss why the other options are incorrect. So option A, IV fluids, is incorrect because although we might need fluids to increase the blood pressure in this patient with anaphylactic shock, fluids won't treat the underlying process, whereas intramuscular epinephrine can. Again, it causes vasoconstriction and it increases bronchodilation. Next, option C, IV prednisolone, is incorrect because although corticosteroids can be added as an adjunctive treatment for anaphylactic shock, they actually take a long time to get started, whereas epinephrine is something you can inject super quickly and it acts super quickly. Finally, option D, oral diphenhydramine, is incorrect because although antihistamines might gradually alleviate the symptoms of anaphylactic shock, they're just not as fast as the epinephrine. So choice D is wrong for a similar reason as choice C. You want to give something fast and effective, so you'd start with B, even though you might eventually give C and D as well. So you might give steroids and antihistamines. But start with epinephrine. And that concludes this section.